So, no, I am not following the chapter in order. We're looking kind of up to some electrocardiography. This chapter, chapter 18 in your book, is actually split into two block exams. So the first exam will cover everything up through ECGs. The second block exam will begin at 12 lead ECGs to the end. So the bulk of it is the first test. Both your cardiology tests are 75 questions, your neuro test is 75 questions, but some of the other tests are only 50 questions. So, your heart, now this is a little large scale human heart, but heart sits about like this in the human body. If you notice the bottom of the heart, this is actually called the apex of the heart, the pointy part of the heart, rests down here and it kind of angles forward. Okay, and that's important to learn is the heart, it's not perfectly straight up and down like this, it kind of angles a little bit forward. And it slightly angles to the left, the patient's left. So what we're really concerned about is the electrical conduction system of the heart. Now, this doesn't show the electrical conduction system, right? But starting kind of back in, right about here where my finger is where the SA node would be, the sinoatrial node, right? It's actually in the right atria, right atrial tissue, and it's right near what is called the coronary sinus, where the sinus part comes from. So what's the coronary sinus? Anybody ever heard of that before? Looking at your nerd notes.
Chapter 18.
Yes, chapter 18. So I'm not going in order. I've moved ahead a little bit. No. Good guess, but no. So up to this point, 21 steps of circulation. Blood came back to the right atria via the superior and inferior vena cava. One more thing that dumps blood into the right atria. So all these little vessels that go on the outside of the heart are coronary arteries. There's also coronary veins, and that dumps back in the coronary sinus. There's actually three things that dump blood into the right atria. Inferior vena cava, superior vena cava, and the coronary sinus, which is basically the coronary veins. Does that make sense? Okay. So that's about where the SA node is. There are three branches, right? Bachman's, Winkie-Bach, and parietal, which connect. They're also known as the internodal, between the nodes, internodal branches, okay, from the SA to the AV node. The AV node sits kind of right about where my finger is, not actually on that valve, but right in that general area. Okay. It is the atrioventricular valve, or I'm sorry, node, atrioventricular node, because it's between the atria and the ventricles. In fact, it is very unique with the electrical conduction system. I'll use green here. You can actually see it on this heart model. Everybody sees this tiny little yellow line? That is a little layer of fat, about 2 to 3 cells thick. And it goes right about here. And that's very, very important for electrocardiography. So that tiny little layer of fat cells do not conduct electricity. So the only way to get an electrical signal from the top of the heart to the bottom of the heart is through the AV node, the only normal way. We'll talk about some other pathways, like somebody can have a birth defect where there's an extra pathway or something like that. That was actually what my brother had. It's called bundle of Kent. And he was prone to a condition like Wolff Parkinson White, and his heart rate would get up in the 300s because it bypassed part of the electrical system here, kind of short circuit.
Can additional fat accumulate on there?
Yes, additional can accumulate on there, but there's always going to be a little bit. It has to act as that insulator. Okay. So coming off the AV node, there's this thick, kind of fibrous band of cells and they act more like an electrical nerve cell, but it's really muscle cells, they don't really contract much, called the bundle of His, and it's pretty thick, okay? About as thick as your little finger, but only super short. And then it will quickly branch into a right bundle branch and a left bundle branch. If you notice, the right bundle branch is very skinny, the left bundle branch is very thick. It's important. The left will then branch again into the left anterior bundle branch and the left posterior bundle branch. So imagine in 3D, it comes down the left side and one is going to wrap around the front, the other one is going to kind of wrap around the back. So that's what this is represent. Why do you think the left bundle branch has a thicker branch than the right? It needs more electrical signal. Why?
Push it through the whole body.
There's more muscle over here. Right? So purely because there's more muscle over here, we need more signal going to the left side. All right. At the end of all the bundle branches, you have these tiny little fibers, they call Purkinje fibers, which kind of go through multiple sites in the nerves, or in the muscle, in the heart muscle. So what were my characteristics of cardiac cells? Automaticity, they can create their own signal. Important, because it's the only cells that can create their own electrical signal. All right, what else? They can be stimulated from another cell. Okay, they can contract, right? So they're excitable, they have automaticity,
Conductivity,
they can conduct a signal,
contract.
and they can contract. Right? Other cells have those abilities except for automaticity. So we'll come back to automaticity in a minute. But I want you to think of that excitability. I can stimulate that cell. It's almost like a bunch of dominoes. I push this domino over, it knocks over this one, knocks over this, it kind of cascades. Think of like throwing a rock into the water. You get those waves that go out in all directions. Same thing happens here. So I'm going to just erase some of these labels. Is that okay? All right. I'll leave the system up there. Oh, and forgive me, the AV node and bundle of His together are sometimes called the AV junction. So I don't want that to confuse anybody. All right, so what do you think would happen if I started my electrical signal where it normally begins, up here in the SA node? Think about throwing a rock in the water. Plunk, the rock hits the water, and what do I get? Ripples that go out. So that is depolarization. Okay? So somewhere in that cell, in that SA node, the group of cells there, one of the cells depolarizes. How's Chipotle?
Good. Pretty good.
You got it right. Good guess. So, one of those cells, automaticity, creates its own signal. It depolarizes. We learned from last semester in physiology, sodium goes rushing inside, potassium comes outside. So what was the overall change? The inside became more positive. And if I looked at that on a graph, right, don't look at the EKG, we're just gonna look at one cell on a graph, right? It was at minus 90, and then suddenly it depolarized. It became positive up to about positive 30. And then what happened? Potassium started going out, and calcium started going in, right? And this is right around 0 right there, right? And yeah, the pumps kick in and start resetting everything. To the next peak. That is one individual cell. Okay? Depolarized. So that guy depolarized, right there. But heart cells are excitable. So we have all the cells around it, just like that ripple effect throwing a rock in the water. It caused all the cells around it to depolarize, which causes all the cells around it to
Depolarize.
depolarize. So you're getting this kind of depolarization wave. They say it propagates, it travels through. Now, when it goes cell to cell to cell, all right, I don't want to sound like there's two types of cells, but humor me for a minute. Pretend that's like the nervous system. Pretend it's like the nervous system. Those cells are going to act like a nerve. They're going to send that signal super quick. The other cells are just regular heart muscle cells, right? They don't send the signal super quick, so they take a little while. I want you to think of it this way. Who's got a big four-wheel drive truck? All right, you ever go mudding?
No. Oh, have I ever?
Yeah.
Oh, yeah.
Maybe not that truck, but yeah. So how fast can someone go mudding? No, your engine might be running a lot of RPMs. How fast are you going through the mud? You're not doing 80, 90 miles an hour,
No.
right? No, except, yes. My point is, when you're going through the mud, when you're going four-wheel drive, right, you're not going as quickly as you were if you were going down the highway. Think of this as the highway, and all the other cells as like going mud. So now, we got to the edge of the SA node, and that signal all of a sudden is over here, starting to depolarize. And all of a sudden it's here. Talk about AV in a second. But the rest of it, it's going cell to cell to cell, and the same thing is happening over here. You're getting those ripple effects. So this branch here, Bachman's branch, Bachman's bundle, okay, goes not just to the AV node, but it also goes off the left atria. Why? Because I want my right atria and my left atria to do what? Contract at the same time. Well, it's virtually instantaneous. So we're getting depolarization on both sides, and we know once the cell starts to depolarize, the calcium goes in, the muscle starts to contract. So we're getting both atria to contract. And then they start their reset process, repolarization process. Now, what would happen when that gets down here? Can it get through that layer of fat?
No.
No, and that's super important. So only the atria are depolarizing right now. And the signal gets to this AV node, and it gets to that AV node pretty quickly. And that AV node has a very, very, very important job, multiple important jobs. Right? But this job here is, it is to
Slow it down.
pause, not slow it down, to pause, to delay sending the signal down. Why? Well, I can't have the top of the heart and the bottom of the heart trying to contract at the same time, because they're gonna work against each other. So I have to let the atria squeeze, and then the ventricles squeeze. So the blood gets pushed down and the blood gets pushed out. Right? That's the most important job at this moment. Pause, giving a chance for the atria to squeeze. Then what happens? He sends the signal down, right? So he starts to depolarize, and almost instantaneously, it's all the way out to the Purkinje fibers. So getting depolarization at all these different areas. You get the idea. Why do I need it to go down there and not work from top to bottom? I need it to work from bottom to top. Why? what good would it do to start squeezing the ventricle here, and then here, and then here, and then here, and then here? I need the blood to go
Up.
so I need to start at the bottom and squeeze. You don't grab a toothpaste tube at the top and squeeze it. You kind of have to work it from the bottom up to get all the toothpaste out, right?
The kid has to figure
So
it out. What if you're
that's the electrical conduction part. All this depolarization and repolarization. So what is this ECG thing, right? We are actually looking at what they call a sum of the vector analysis of every depolarization wave. All right, everybody's head's about to explode, I see that. So what am I talking about? What's a vector? Anybody?
Direction and magnitude.
It has direction and magnitude. Most important thing here is it has direction. Which way is the signal moving? So forget cardiology for a second. We'll talk about something you learned in EMT school, kinematics of trauma. I'm driving in a car 30 miles an hour south. A car traveling at 40 miles an hour south rear ends me. Right? How hard was that impact?
15 miles per hour.
10.
It was
40
30.
minus 30.
Oh, I thought you said 30.
You didn't know there was gonna be math.
Yeah.
Right? So really, it'd be like if you were sitting still and somebody hit you at 10. That's kind of the vectors. What if this guy was doing 30 north and 30 south?
It's 60.
All right. So kind of have that, you have that idea? So now if I drew an arrow 30 miles an hour this way and put another arrow 30 miles an hour in the opposite direction, what's the sum of the change?
60?
There's no change, right? That's vector analysis. So when I look at these cells, I'm going to erase the red here real quick.
And those, like,
That's the only reason I know that.
all of that stuff comes down and becomes, what do we, like it's being charged, right?
Mhm.
Do the cells or the fibers that receive it have to be in a certain state of
Yes.
charge?
Yes, and we're going to talk about that in just a second.
Sorry.
Don't make fun of her nerd notes. It's all good.
I don't have that written down yet.
That's how nerdy she is.
I only got through like 6 pages of the chapter.
All right. So let's pretend, I'm going to use a couple different colors here. Right, I have 4 different colors. This cell, right, depolarized like that. Kind of moved in that direction. And the cell next to it kind of went like that. And the cell over here kind of went like that. And the cell over here
And you're referencing each of those red dots you drew, right?
yeah,
Okay.
kind of went like that. If I added those arrows together, these two kind of cancel each other out, don't they? But I got a big one here and one here. So my overall average, if you will, would look something kind of like that. All right. That's the basics of what we're talking about. So keep that thought in the back of your mind. So we're going to talk about ECG leads for a second. Everybody knows where to put the electrodes on a patient, right? Which one goes here?
Salt.
White, salt, yes. Black, right, pepper, right? Ketchup, the red one. Green, okay. The 4 limb leads. right arm, right leg, left leg. So the reality, we put them on the chest. But if you wanted to do true physiology, right, it works on what's called Einthoven's triangle. Einthoven was a German electrophysiologist who came up with this. So imagine a person standing like this. Okay? Right arm, left arm. And in this case, they use the left ankle, but it's really just, the left foot. So if you just use those three, you kind of have this perfect triangle. So I'm going to bring up a different picture here. Right? You get that idea? Okay. When it's on the chest, the triangle gets a little skewed. That's okay. It's perfectly fine for what we need to do for ECGs. It will work. So if I looked at this part, this leg of the triangle, going from my right to my left arm, going across like this, we call that lead 1, and these are Roman numerals. If I looked at from my right arm to my left ankle, going down like this, we call that lead 2. And if I looked from my left arm down, we call that lead 3. That's the 3 parts of this triangle. The important one for us is lead 2. Anybody want to make an educated guess why lead 2 is the important one?
You can go.
The path that the electricity travels.
Lead 2 kind of follows the electrical pathway here, doesn't it? So all of our interpretation rules are going to be for lead 2. So what does this mean, lead 2? I want you to think of the lead is where the camera is. Okay? And the signal always goes towards the camera, from negative to positive. From negative to positive. Negative to positive. Because these leads require 2 wires, they are called bipolar. Chest leads, like in a 12 lead, are called unipolar because they only need 1 wire. But the lead is where the camera is. Now, anybody here play baseball or softball? If you don't, you're familiar enough with the sport. I just want to I'll make a couple of baseball analogies. If an object is getting closer to you, right? If I picked up whatever, I picked up this, and you're looking at it, Ken, you're looking at this right now, and if I throw it towards you, and you don't do anything to protect yourself, as it gets closer and closer and closer, it's getting bigger. If the electrical signal gets closer to the camera, it goes up, it gets bigger on the ECG page. If it's going away from the camera, it gets smaller, it's going down. So going up on the ECG paper, going towards the lead, going down is going away from the lead. So if I notice this rough standard ECG heartbeat here, my P wave went up. What does that mean?
Going towards.
And I'm in lead 2. So my P wave, which is my SA depolarization, my atrial contraction, boom, did the signal go closer to the camera?
Yes.
Camera's down here. P wave is up. There's a pause. What's his job?
Pause.
Pause. Okay? The QRS, it's a combination of 3 waves, it's not like a P wave. It is these guys up here resetting, all of these guys down here depolarizing. So, remember my little vector analysis? Where is there more cells? Bottom or top? Bottom. So this, you lose the reset reset waves because there are just so many waves, I'm depolarizing at the bottom. So I dropped a penny into the ocean. Caused a little ripple. That's my reset wave for my atrium. And a meteorite crashed into the ocean. Big giant waves. That's my depolarization. Do I even see the effect of the penny?
No.
No. So I lose the repolarization. It is happening. I just can't see the repolarization. So if that was one cell, I'll use another color. The very next cell would look like this. And the very next cell, you get the idea. When I put all of those waves together for the SA node, I see a P. I get this guy. When I'm doing all of these waves down here for the QRS, and there's so many more muscle cells, I get so many more waves. That's the sum of all of these vectors. Now, why does this look a little different? Anatomy. That signal, lead 2, remember? That signal went down to the AV node, and because the way the muscle is shaped, it naturally will go ever so slightly back towards your spine, and then down toward the ventricles. Well, it went down ever so slightly back, ever so slightly backwards, and then it shoots down to the ventricles and back up away from the lead, right? So it gets closer to the camera and then goes away from the camera. And then the T wave is what? These guys down here resetting, repolarizing. So a basic understanding of what the waves mean will make interpretation easy. Okay? Everybody good with that so far? Anybody's head about to explode?
Yes,
Yes?
yes.
Okay, what? No.
I'm not getting the camera part, so I mean,
Okay. You're the camera. The signal from you to me, or from me to you, all right, is lead 2.
okay,
Okay? So that's this. Here's the SA node. It depolarized. That wave went towards the AV. Did it get bigger?
yeah,
That's your P wave. At the AV node, that wave goes slightly backward, because the way it's shaped. And then it rockets down to the bottom of the ventricles. That's your Q, R, and then as it travels back up through the ventricles, away from the camera, S wave. And then as it resets, it's the T wave.
okay,
Does that help?
yeah,
Okay.
thank you.
No problem. So the ECG, the electrocardiogram, and you can say ECG cardio, or you can say EKG cardio, K is just a German spelling, tomato, tomato, it's the same thing. A lot of this was developed by German physiologists. So ECG, American spelling, EKG, German spelling. That is just a sum of all these electrical signals. Now, just like I use destiny for that lead 2 signal, I want to pretend Will is looking at this exact same signal. Is this getting any closer to Will?
No. No.
Not really. So if it got no closer to Will, what did Will see?
No
Did
change.
anything go up?
No.
Did anything go down?
No.
Perfectly flat line. Well, Will thinks it's a systole from his
View.
point of view. We always do interpretation in lead 2 because it follows the electrical pathway. Okay? So humor me for a minute. Lead one. Right? So Need of Destiny was lead two. Need of Brandon is lead one. That signal goes like this. We get closer to Brandon?
Yes.
A little bit. We get closer to Brandon?
Yep.
It's gonna look very similar, but not the same. Right? Lead three, that's Brandon to Nick. It's gonna look quite different. But ultimately, as that signal travels down from, from this perspective, it's getting a little closer. So we will see changes very similar, but it's not the same. You have to use lead two for these rules. Everybody does interpretation in lead two. Roman numeral two. Roman numeral is very important because in cardiology, 12 leads, there's also lead V2, which is not Roman numeral, an alphanumeric numeral 2, right? And they are very different. And it sounds a lot the same, lead 2, V2, so make sure when you write it, it's definitely Roman numerals or normal numerals. Okay. All right, so to really look at this, we need to understand what the ECG paper is. So, Bianca, catch. Grab as much paper as you would like. Will? Page, pen? Fred? All right. Grab a nice, big, healthy piece of paper. And you can take notes on this if you so choose. It's faded. You want to keep the whole thing? That's fine.
I don't wanna share it with anybody.
All these are different pieces of paper for different cardiac monitors.
Is the phone hot or these?
Okay. This is old.
Oh, yeah, at least the thing that one of the uses.
From lead two goes down, it's following the path of what, repolarization?
It's following the SAA ventricle path. It's the normal path that the heart electrical system would take. So I'm gonna go back to that other diagram.
Yeah, I know they tested. I tested it.
Yes. I'm gonna come back to
10:30.
this.
Drug test like 10:30 to 11.
So again, lead two,
11:30.
this is kind of the pathway the signal would travel through the heart. Lead three, lead one. I'll get to these in a bit. What I want to do is bring up the ECG paper.
I fucking went to they're gonna hire one as like a girl that tested it for me. Trying to read the girl. I want to tell you one of four.
There's only 5, so.
I didn't pick the girl.
Maybe she was the best.
I just didn't see her. I didn't. I feel like usually when there's like a girl that I try to like take down.
So basically, ECG paper is nothing but graph paper. Right? The boxes are tiny.
Yes.
And yes, we are actually talking about these little teeny tiny boxes. And then we'll see if focus that's a little better. Right? So like there's 1, 2, 3, 4, 5, 1, 2, 3, 4, 5, 5 by 5 in one of these bigger boxes. Those boxes, it's standardized, are 1 millimeter by 1 millimeter.
The small ones.
The teeny tiny ones. The smallest boxes are 1 millimeter by 1 millimeter. 1 millimeter by 1 millimeter. The paper has to come out of the machine at a certain speed. And machines have to be calibrated. Right? It comes out at 25 millimeters a second. So I'm going to start right here at this thick line right at the edge here. 5, 10, 15, 20, 25 millimeters, that is 1 second. 2 seconds. This would be about 3 seconds over here. You get the idea. It has to come out at that speed consistently so we can see nice waves and take our measurements. If it came out too fast, would our measurements be wrong? If it came out too slow, would the measurements be wrong? It comes out at 25 millimeters a second. Now, this is where we get into the characteristics of the different waves. P wave, which Bianca just mentioned, this was the atria depolarizing. Right? So that signal traveled towards the AV node. So which way should it go on the paper?
Up.
Up. So the P wave should be upright, and a normal P wave is 0.06 to 0.11 seconds. Well, wait a minute. 0.06 to 0.11 seconds. I've just told you millimeters. 25 millimeters is 1 second. That's the speed, right? What's 1/25th? If you do the decimal, 0.04. So the box, the teeny tiny box, is 0.04 seconds of time. 5 boxes, 0.04, 0.08, 0.12, 0.16, 0.20. 5 boxes would be 0.20. So I need to be 0.6, a box and a half, to 0.12, would be 3 boxes, right? To a little bit less than 3 boxes in width. So if I was to do it on here, and I'm not sure if I can do it with this, I'm gonna try. Right, my P wave. That's way too big, isn't it? All right, I don't know if I can undo.
Control Z.
Nope. So really my P wave in this pen is too wide. Should look something like that. It's tiny. Again, this pen is too thick. Should be probably something more like. I don't know why it's doing it upside down.
We'll do it one more time. Just like, hey.
So it should probably be something more like that.
So in all reality, 2 boxes being point
Right.
zero.
And it's generally nice and rounded. Generally. I don't want you to get hung up on the, well, it was kind of pointy, or it was rounded, or it was a little lopsided. Don't get too hung up on that. That tells me that the signal came from where? Yes, I know. Okay. If it came from somewhere up here in the atria, it would look a little different, but it would still get closer to the camera. It still goes up on the paper. All right? So upright can be SA node, we call that sinus, or can be atria. What if my signal started here and went backwards?
It goes down.
Inverted.
It would be inverted. What if it started here and just came down this way? Did the top ever depolarize? No.
No.
So I could have no inverted or no P wave, and we call that coming from the junction. It's where these rhythm names come from: sinus rhythm, junctional rhythm. Ventricular rhythm. Starting to get the idea? So the P wave is telling me where it started. But if you notice, that's question number 2. In your book, it's question number 1. I say, give a goddamn where that came from, what it looks like. That is not important. Because I'm going to tell you a big secret. If it started down here, this person's got a couple minutes left to live. Like less than 10. Ventricular rhythms are always lethal. They die, and quickly. It started up here. We got time. Hours, days, weeks, decades until it's a problem. Wouldn't you want to know if I'm dealing with a life and death problem first?
Yes.
That brings me to my QRS. The width of my QRS from the beginning of the Q to the end of the S. That distance right there. Right? All I care is how wide this rhythm is, this wave is. I don't care if it went up and then down, if it went down and then up, if it went up, down, up, down, up, down, up, down. I don't care. How wide is it? Because if it was nice and narrow, it means it's following this electrical pathway. All is good. If it's wide, it means it started somewhere not on the pathway. Because we're going through the mud. We're not traveling down the highway. Right? Because if we're going through the mud slower, that paper's coming out at a certain speed, the wave gets wider. But if we're staying on the highway, that wave stays narrow. So all I care about is how wide that QRS width is. And the rule is less than 0.12 seconds. Well, 0.12 seconds is 3 boxes.
So that.
All I want to know is how wide.
So that whole QRS complex fits in 3 boxes.
It's supposed to.
Okay.
Okay? So again, from here to here, it's that 3 boxes. Sorry.
That's enough even harder.
Looks like yes.
It looks like
Looks like yep.
So I got 1, 2, that's about 3 boxes width right there. I'm not going to play games with you guys. It's going to be narrow. Or it's going to be wide.
There's no like.
I'm not going to do the, well, it was 3.01 box. No. You're going to see the like 4 and 5 or 6 or 7 boxes, or you're going to see the 1.5, 2 boxes. Right. All I want to know is it wide or is it narrow? Now, this is a trick question. Wide means it came from the ventricle. What does narrow mean? Thank you. It's not from the ventricle. It could have been from here. It could have been from here. It could have been from here. Could have been from here. Could have been, but anywhere but the ventricles. So these 2 questions, how wide is my QRS? And what does the P wave look like? Tells me where the signal started. Does that make sense? If the QRS is wide, what does that mean?
Sorry,
It's ventricular. If the QRS is narrow, it's not ventricular. Well, let me look at the P wave. Because if it was a wide QRS, if it started in the ventricles, am I getting P waves? Probably not. There is an exception I'll talk about in a second. Right? So, wide, ventricular, narrow, not ventricular. Wide, ventricular, narrow, not ventricular. All right. The other questions are really easy. How fast is it? Is it regular or irregular? And what is the PR interval? So let's talk about how fast. We can look at the stupid monitor and go, oh, it says 90, right? But you don't get that when I hand you an ECG strip. When I say, what's the heart rate?
You can count the box.
Yeah.
Yeah, I can count the boxes.
90.
Damn, 90 no, it's not 90. Right?
Each box
80
is
something.
a
So,
second.
some ECG paper, right? Can I borrow that one for a second? I'll give it back, I promise. Some ECG papers have markings on either the very top or the very bottom. You see these little markings right here, how it sticks up a little bit? Each is 3 seconds. So between my fingers is actually 6 seconds of time. Right? See these little markings I'm talking about? That Zoll does not have.
Great.
Oh, actually,
3.5 seconds between the black dots.
yeah. And, yeah, don't go by the black dots.
No, I'm just.
Yeah, but it's not correct. Right. So some paper has these markings up top every 10 seconds. Red line sticking up.
The SE knows that the QRS.
See, you got it.
Coming from the top of the bottom of the heart.
So you see that little line sticking up, that little, those are 3 seconds apart. So from here to here would be 6 seconds. 3 seconds. So you have to go to 2 of these for 6 seconds. Can you see what we're talking about? No. Okay, so from that line sticking up to that line is 3 seconds.
Over there messed me up.
From that line to that line, 2 of them is 6
See that?
See that little line sticking up?
Yes.
And that little line? Those are 3 seconds apart.
Okay.
You got,
Yeah.
that's 3 seconds, that's 3 more, that is 6. So if I knew how far apart 6 seconds was, it gets very easy. Count up your QRSs. I had 5 QRSs in 6 seconds. How many would I have in 60 seconds? What's your heart rate?
10. I didn't hear your question, I just shot it over out.
50. If I had 8 QRSs in 6 seconds, how many would I have in 60 seconds? 80. Just multiply it by 10. Right? It is the easiest way to determine heart rate if you have a 6-second strip. Count the QRSs in 6 seconds, multiply it by 10.
This little pump.
Right? Does that make sense?
Yes.
So I'm going to be that guy on your first ECG quiz. They're all going to be 6-second strips. In fact, the direction says, please identify the following 6-second ECG strips. So how do you figure out rate?
Times by 10.
Count the QRSs and times it by
10.
10.
Say again, what you multiply by 10?
If that was 6 seconds,
Okay,
and let's say I had 5 beats in there,
okay.
how many would I have in 60? 6 times 10 is 60. So how many beats times 10 is? Heart rate. You get it?
We'll talk about it later.
Okay.
I'm with you, Megan. I'm lost.
Look,
I got lost like 10 minutes ago, I'm sorry.
so, each of these, this gap here,
Yeah,
2
three,
seconds.
I get that part.
So, from here, here,
6 seconds.
6 seconds. So let's say, 1, 2, 3, 4, 5 in between there.
The QRSs.
Yes, 5 QRSs in 6 seconds.
Okay.
6 times 10 is 60.
But why are you multiplying by
So
10?
5 times 10. Because
Because I'm only counting 6 seconds, I wanna know what 60 seconds would be.
So you have to times this amount by 10
Or you can
to get 60 seconds.
print enough EKG to wallpaper your bathroom.
It's beats
So
per
it'd be
minute,
5
so you
times
multiply
10
it.
to get 50 beats per
So,
minute.
so you're gonna check a pulse, right? I want you to count how many times you feel a pulse in 6 seconds. Boom, 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 boom. Oh, I felt 8 heartbeats in 6 seconds. What's the heart rate? How many in 60 seconds? 80, right? It's a, forgive me, shortcut, cheat method, okay? But it is the simplest way to get a heart rate. There are other ways you can do it, right? One of them is count how many little tiny boxes and divide by 1,500.
Jesus.
How many big boxes divide by 300? That's math. Times 10's pretty easy. We can do that one, right? The other one, and I want you guys to learn this, right? I'm gonna write it right here. Three hundred, 150, 100, 75, 60, 50. What am I talking about for this? I want you to look at the ECG paper, right? And I have a QRS. I don't care if it went up or down. That landed right on one of these dark lines. Okay? And I want to look at the next QRS. This method here is also a shortcut. If my QRS, my very next one landed on this line, the heart rate's 300. If it landed on this line, the heart rate is 150. If it landed on the third one, the heart rate is 100. Let's do that math. All right? 0.2 seconds would be 5 boxes. 0.2 seconds. Right? Every 0.2 seconds, we got another beat. Right? So 300 in a minute, 0.2 times, or 65 by 0.2, 300. You don't have to do the math, you just learn the numbers. Here would be 150, the next one would be 100. The next one would be 75. So, again, I'm just gonna put this one up here. Now,
If there wasn't one there and the next one was there, it'd be 150 instead.
Okay.
Right now, you have, yeah.
300.
So, if there wasn't one there, and there was
we're just looking at rate.
If there was one here, it'd be 75. If there's one here,
Right.
it'd be 70. Yeah, or it should be 100.
This landed right on the line. Everybody agree that's like right on that dark line? So if the next one was here, it would be?
75, 60, 50.
Right? There's a reason we're stopping at 50. It's too slow, right? What do we call heartbeats that are too slow? Yeah. Whether it was 55, 45, 25, to, it's still Brady Carter, right?
So you're going between the two, basically. So like, say this guy over here was where these other little squiggles that aren't supposed to be there are at.
Yeah.
Yeah, so you're counting between the two.
Yes.
Okay,
Let me see if I can.
that's easier than whatever.
That's only the land.
So we use different ones here.
Like that.
Find one that lands on the line.
They skip 2, it's 100, and it continues.
2 seconds.
Heart rate here is about
150.
pretend it was on the line. Heart rate's a little less than.
50.
It's another quick way of figuring out, but it has to be pretty regular. And I say it has to be pretty regular. $300, $150, $175, $300, $150, $120. It's not regular. It only works if it's regular, but it gives you a ballpark, an idea of what's going on. I don't want to sound like I don't care about the rate. I don't give a crap about the number. Right? I just want you to be able to tell me it's too fast, it's too slow. You get the idea.
So what's all that garbage and just that dollar factor?
This is a different rhythm we'll get to. This actually brings me to regularity.
Gotcha.
That would be irregular,
Yeah.
where regular is like a regular. Right? Like, that would be regular,
Yeah. Irregular.
irregular, because that's another question in my classification.
Okay.
The last part is this PR interval. The distance from the beginning of the P to the beginning of the QRS. I don't know why they don't call it PQ interval, but it's PR, right? That's gonna tell me how long this guy paused. Remember, his job to pause
Yeah.
signal? So a normal pause is 0.12 to 0.20 seconds, 3 to 5 boxes. Again, back to baseball, softball. Ball's hit to the outfield, center fielder catches the ball, runner's trying to get to home, tag up, right? So he throws to the shortstop, the cutoff man. The cutoff man. And that cutoff man does what? And sends the ball down the home plate. Catches the ball, sends it to home plate.
We're talking about two things I don't know about now.
Right? What would happen if that cutoff man went and sent the ball to home plate? He takes too long. What would I see?
Long to P to R interval.
That distance gets longer. What does that tell me? He's taking too long. That's one of the heart blocks. That's a first degree heart block.
So basically, if it's bigger than one square, it's too long.
One big square, yes. There are other types of heart blocks. Right? Second degree type 1, second degree type 2, and a third degree. There are 4 heart blocks. Second degree type 1, right? It's over multiple beats. First cutoff man, sends it home. Next one, sends it home. Next one. Next one. What's happening? Everyone is getting longer until he goes, minute of runner score, whatever he does, and throw the ball home. The signal doesn't go through. And it resets. and it repeats that pattern, and it resets, and it repeats that pattern, it resets, and it's very predictable. Second degree type 1, also known as a Winky Bach. We're gonna go over this more, don't worry. Second degree type 2, ball goes home. Ball goes home. Ball goes home. Goes home. Not predictable. Everything's normal, but just some signals aren't going through. That's not good. Second degree type 2. Classic heart block. Third degree heart block, also known as a complete heart block. Here's that shortstop going. Not throwing the ball home. Nope. Not a signal gets through. Everything gets here, nothing goes through. Complete heart block, third degree block.
What is that?
I'll show you. Give me a couple minutes. So, an easy way to remember your heart blocks is a marriage gone bad. You don't listen. All right, a marriage gone bad. So, somebody pick the guy or the wife, or the husband or wife.
Husband.
The husband. Okay, the husband. So, you got the wife, the P wave, and you got the husband, the QRS. Right? And they're married, and there they are, arm in arm, PQRS, PQRS, PQRS going through life. Side by side, always there. And a first degree block develops. Marriage isn't as strong as they thought. They're still there for each other, but they're a little further apart. They're not walking arm in arm, they're not holding hands anymore, they're kind of like, we're here together. All right? So then, they go to marriage counseling. They're back together, it's Monday. Tuesday, he stayed a little bit late at work, didn't want to get home. Got home a little late. Wednesday, stayed a little later. Thursday, stayed a little later. Friday, he didn't go home, he went out with the boys. Saturday, he feels guilty, he comes home right on time. Sunday's a little later, Monday's a little later, Tuesday's a little later. Wednesday, he doesn't come home. Second degree type 1. So go back to counseling. Monday, he comes home on time. Tuesday, he comes home on time. Wednesday, he don't come home. Thursday, he comes home on time. Friday, he's home on time. Saturday, he's home on time. Sunday, he's not home. Monday, he's not home. Tuesday, he's home on time. Wednesday, he's not home. Thursday, he's home on time. Friday, it's not predictable. That marriage is falling apart. Second degree type 2. So what do?
Good counseling.
They get divorced.
Layer it up.
SA no does its own thing. Right? Ventricles do their own thing. No signal, no communication, no connection. P waves, QRSs, not talking to each other. And you can see this on an ECG. Now understand, all of this is rhythm analysis. The rules for 12-lead ECGs are totally different. And I know the heart monitor is a device used for a test. A ECG rhythm interpretation and a 12-lead ECG are two very different tests, even though it's the same machine. Please be specific. I want to put it on the monitor is the rhythm analysis. Get a 12-lead is the 12-lead analysis. You always, always, always do the rhythm analysis before you do 12-lead. What's going to kill them first? A rhythm problem. So step 1, the 12-lead analysis, do a rhythm analysis. So we'll always do the rhythm first. Pretend it's like your stethoscope. Can I listen to lung sounds with your stethoscope? Mm-hmm. Can I flip the bell over to the other side, listen to like heart tones or fetal tones? Mm-hmm. It's the same device, but it's two different tests. Your cardiac monitor is two different tests. Okay? So, if you follow these steps in order, we can figure out what our ECG rhythms are. Okay? So we'll do some practice with this.
Morehouse, what does FLB stand for?
Oh, that's the last step. Funny looking beats.
Oh.
That was, gotcha,
Funny looking beats.
gotcha.
The rhythm is one thing, but there's a one weird beat in there. A funny looking beat. Which those are not really life threatening. We don't worry about that. It is. Now it's. All right. So, looking at the QRS, would you say that QRS is wide or narrow?
Narrow.
So it is
Not.
not ventricular. My next step is I'm going to look at the P wave. And my P wave should be upright and pretty rounded, right?
Yep.
So we typically call that
Sinus.
sinus. So this is sinus,
Rhythm.
sinus something,
Yeah.
sinus something. You have to also, for rate, once you identify where it came from, you have to, I hate to say, learn a couple basic terms. The SA node normally is what rate? 60 to 100. What does tachycardia mean? What does bradycardia mean? Please remember those definitions. Very specific. Over 100, less than 60. Okay? So, we're going to call this sinus. Narrow QRS, there's a P wave. Let's see, can I figure out rates?
About 6.
Below 75.
About 75. Right? I'm using this rule, except I'm cheating, I'm saying in the middle of the box, 300, 150, 100, 75. 75. Could it be 70? Could it be 76? Could it be 72? It's a ballpark, right? Is it in that range?
Yes.
Huh. So this looks like it is a sinus rhythm, a normal sinus rhythm, but we're not done. Is it regular?
Yes.
Yes.
Sinus rhythms are regular. Is the PR interval normal? The beginning of the P to the beginning of the QRS, is it less than one big box or less than 5 little boxes?
Yes.
So this is a normal sinus rhythm.
Okay.
Try to keep these in order here. QRS, wide or narrow?
Narrow. Not ventricular.
Not ventricular, thank you. P wave. Looks a little pointy, but it's there. Why does it look pointy?
Sodium? No idea.
Because that's the way.
Maybe it started here. Maybe it started here. Maybe it started here. Maybe the camera angle was here, or here, or here, or here. Don't overthink that. Okay? QRS is narrow, P wave is upright. Rate, let's see, 300, 150, 100, 75, a little above 60. Is it normal?
Yeah.
Is it regular?
Yeah.
Is the PR interval normal?
Yes.
Sinus rhythm.
Is the height of it, is that?
Means nothing.
It means nothing, doesn't.
Not for rhythms. It does mean something for 12 beats.
Like for the strength of your
Yep, but it means nothing for rhythms. QRS, wide or narrow?
Narrow. Not ventricular.
P wave.
Upright.
Okay. Rate, let's see, 300, 150, 100, 75, a little faster than 75, is it?
Yeah.
Okay, normal?
Yeah.
Regular?
Yeah.
PR interval good?
Yep.
Yeah.
These have all been sinus rhythm. Wide or narrow?
Narrow.
P waves,
Upright.
all right? Regular?
Yep.
Yeah.
Rate, 300, 150, 100, 75, 80.
Yeah.
Regular?
Yeah.
PR interval,
Yeah.
Mm-hmm.
sinus rhythm.
Yeah.
All right. What? QRS, wide or narrow?
Narrow.
P wave,
It's
Upright.
It's upright.
It's
small, but it's there. All right. Rate, 300, 150, 100, something about 80.
Yeah.
Yeah,
Okay. Regular,
Yeah.
yes.
PR interval,
It's there, yeah.
Yeah.
A little wide,
is it?
it's like 4 blocks.
It's, but it has to be bigger than 5
Right.
to be wide, so it's not wide.
It's good.
Sinus rhythm,
Yeah.
Yep.
Yeah.
this went down. But this is jacked up. Where does it say QRS up or down?
It doesn't.
Where does it say ST elevation? That's a step,
Yeah.
right? Because this is the QRST and it's elevated. Where does it say that for rhythms?
It doesn't.
What is that?
Normal sinus rhythm.
I wouldn't call it normal, but it's a sinus rhythm, right? Don't try to memorize a picture. Follow the rules.
Gotcha.
Wide or narrow?
Narrow.
P waves,
Yes.
right? Rate, 300, 150, 100, about 80, okay. Regular, PR interval,
Yeah.
Science.
we'll skip these two for a minute. There we go. QRS, wide or narrow?
Narrow.
P waves,
Upright.
Upright.
is it regular?
No.
No. Yeah, it's just fine.
It's pretty regular.
Yeah.
What's my rate?
Fast, yeah. That's
Right.
300, 150, 100, 75, 60, 50, a little less than 50. PR interval good?
Yeah,
Sinus,
Bradycardia.
bradycardia,
gotcha. That's under 60.
just under 60.
Okay.
I like the box thing, way better, whatever, that,
Okay.
that's my stuff, that's
Start
my.
reading.
The brain.
Again, I'm trying to keep these relatively in order. There we go. This one.
Oh, geez.
Sinus tachycardia.
QRS, wide or narrow?
Narrow.
P wave,
Yes.
Upright.
rates,
100.
300, 150, 100. Ooh, it's more than.
hundred.
Sinus tachycardia.
PR interval good?
Yep.
Is it regular?
Yeah.
Sinus tachycardia. There are 4 sinus rhythms, or 4 SA rhythms. Sinus rhythm, which means the rate is between
60 and 100.
sinus bradycardia,
Less than 650.
sinus tachycardia,
About 100.
and then the weird one,
What's this?
sinus arrhythmia. It's ever so slightly irregular. Because just imagine, and I'll use me back when I used to be skinny. I have a wire here, a lead, and a wire here. I take a deep breath. They moved apart ever so slightly. They got ever so slightly closer. Right? It's not really the movement of the wires, but it's what that does. I put pressure inside my chest, my heart rate is going to ever so slightly speed up. I decrease the pressure, it ever so slightly drops. So it's not regular, but it like follows the breathing pattern ever so slightly. It's still perfectly normal. Sinus arrhythmia. You probably won't see it in a 6-second strip. You know, if you hit print, you forgot to turn the print off and you got like paper like this, you might notice it. You know. So that's it. Sir.
When you're doing like the shortcut, to figure out the, you know, heart rate,
Mhm.
are you measuring from the R wave or the S wave?
It doesn't matter.
Okay,
You can pick either one. Just be
Okay.
consistent. Like I can't go this S to this R.
right, but if you do, like, on those same two that you were pointing at, if you use both Rs, that could be, you know, seen as almost 100.
Well, so 300, 150, it's more than 100.
Okay, because it's not exactly.
It's not exactly, and that's all we're looking for. It's a ballpark estimate.
Right, okay.
Same thing if I'm doing here. And officially, the rule is you find the one on the dark line, and you can. If you want to, forgive me, cheat, I can sit here and go like, well, that's almost in the middle. So almost in the middle would be 300, almost in the middle would be 150, almost in the middle would be 100. Oh, it's more than 100. And, you know, it's, as long as you're getting the same distances.
Okay.
Real world, they take calipers. And they take the two calipers and they go, and then they go, and they measure to see if it's regular. You can also use what they call a poor man's caliper, where you grab a piece of paper and you mark that paper. And you mark the next QRS. And you go, yep, nice and regular. Right? Real world. But again, it's going to be blatantly obvious or not. I'm not trying to do this super crazy, weird, tiny stuff. Where was I? So we get the idea with sinus tachycardia. How about that one? Ho ho! A little funky. QRS.
Narrow.
Narrow. P waves. Rate. 300, 150, 100. It's probably like 130, 140, you know, it's up there. Is it regular?
Yes.
PR interval?
Yep.
It is.
Sinus tachycardia.
Looks funky as hell, but it's still sinus tachycardia.
Why does it look like that?
STEMI. That's also a STEMI.
Oh,
It's actually part of an inferior wall STEMI. QRS.
Yep. Narrow.
It's narrow. I know you're like, well, all the way over to here. No, that's not the QRS. The QRS actually is that. And this one trips people up. Don't feel bad. So narrow, P wave is good. Right, it's regular, PR is good. Rate 300, 150. It's about 160. This actually has ST depression, which happens before STEMI.
How long will you see depression before elevation, typically?
Could be seconds, could be hours.
Okay.
So are all these readings from lead 2?
Yes,
Okay.
purposely from lead 2.
Would you wait until you put on a 12 lead to call a STEMI?
Yes, because you have to look at multiple views. You need many cameras to call a STEMI.
Gotcha.
So I want to switch this up ever so slightly.
Did you text me in class?
You said 4 is better than what's the
Oh,
12?
sorry. I tried texting it too. Somebody just called me. I forgot I was texting you last. So
STEMI, infarction. Heart attack.
To diagnose?
Yes.
I forget you were the last person I texted, so I pulled up on my watch
4A
and straight to you.
Well, it's not 100% diagnostic, but it's heart diagnostic. Okay. QRS. Is it 3 boxes? This one's kind of on the limits. All right? So for right now, pretend that's narrow. Okay? P waves,
Upright,
regular,
yes.
rate, 300, 150, 100, 75, 60, like what, 55 maybe, 52, but it's PR interval.
Long.
Long.
Well, if the PR interval was normal, we would call it a sinus
Brady.
Brady, but it's long, so we would call this a sinus Brady with a first degree heart block. Now, I mentioned before, why QRS is ventricular. There is one exception. That's it.
Heart blocks.
Not necessarily heart blocks. Two exceptions if you want to count heart blocks. Heart blocks are their own thing. This is actually called aberrancy. And what that means, this is more of a bundle branch block. This is deep 12 lead stuff. But I don't want it to confuse anybody initially. So what do you think would happen if that part of my heart was damaged? SA no fire. Went to the AV, spoke. AV held it, sent it down to the ventricles. It goes down to the ventricles, well, it went to the left side super fast, but it couldn't go to the right side. Why? So this side depolarized, and then it had to go through the mud, which made that QRS get wide. Did it start in the ventricles? How do I know that did not start in the ventricles? Because it's got a consistent P wave. Right, so that is a bundle branch block. They call it aberrancy, not normal conduction. I don't want that to screw anybody up on the rhythm analysis. All right. Oh. These are heart blocks, so I'm gonna do this one, then two, and then we'll go back to a heart block. QRS, wide or narrow? P wave.
None.
So where did it start?
Junctional.
Not the ventricle. Why is it not the ventricle? The QRS is
Narrow.
narrow, but there's no P wave, which means it came from
Junction.
the junction. Junctional rhythm. Means the top of the heart wasn't working right. Did the atria fire? Did they depolarize? No. So we're only getting that rhythm. All right, so rate. 300, 150, 100, 75. So we're probably 80, 85 here. But that's not normal for the junction, is it? What's the normal rate for the junction?
40 to 60.
Huh. So if I called it junctional, it means 40 to 60, but it's 80. I can't call it tachycardia because tachycardia means over 100. So I have to call this accelerated junctional. It's junctional, but it's faster than it's supposed to be, but not fast enough to call it tachycardia.
Okay.
Accelerated junctional. Wide or narrow?
Narrow.
P waves.
No.
Regular.
Good.
Rate. 300, 150, 100, 75, so about, again, 80. PR. There can't be a PR interval. Why?
Because no P wave.
There's no P, so again, this is
Accelerated junction.
accelerated junction. If, pretend, if the rate here was 50, what would we call it? Just junctional rhythm. But if it's above 60 but less than 100, we have to call it accelerated. Because the normal pacemaker heart. All right, so as I said, we'll talk about some blocks for a second. QRSs.
Narrow,
Everybody agree?
Yeah.
P waves.
there.
Upright.
Okay. Rate. 300, 150, 100, 75, 60, if you really want to know the numbers. 50, 35, 15. A little slow, right?
Yeah.
You know, heart rate is really, it's definitely slow.
Yeah.
Can I call this science?
Yes,
No.
no.
Why can I not call it science? What is my PR? Here it looks,
Short.
Wide.
here it looks,
Why?
where's the QRS?
Nowhere.
Where's the QRS? Where's the QRS? And I'll even move this down this way. Here, are they talking to each other?
No second degree?
No, this is actually a third degree. The P waves, and if again, I took my poor man's calipers. Right, and I did the, let's see, whatever. That's the P wave distance I went. Yep, my P waves are nice and regular, so my SA node is going.
It's shooting up there.
And no signals are going through. So my QRS is like, my venture was going like, dude, if nobody's gonna tell me to beat, I'm gonna beat on my own. At what rate? Which is why my QRSs are doing their own thing. They're completely blocked from each other. They're not talking to each other. They're completely heart blocked. The reality, people screw up the heart blocks all the time. It doesn't matter that much. What's wrong? It's too slow. What do we need to do?
Speed it up.
Speed it up. Right? Basic. Right? That's what I mean by don't try and overthink this crap. It's not that hard. It's not rocket science. It's new. It's different. I get it. It takes some practice, but it's not crazy, crazy weird. All right, so. That's a tough one. We'll use this one. QRSs. Oh, I'm sorry.
That last one, pacing as well, like that hemodynamically
Unstable, yes.
That would fall into that as well as,
Okay,
or chemical.
so that's my patient. Holy shit, their heart rate's 20. They're like, yeah. Feel a little bit tired. Blood pressure's 140, skin is good, mental status is good. How bad is it? Most people like that are barely conscious, pale, cool, sweaty. Well, pale, cool, sweaty, unconscious, like bad. Oh shit, symptomatic. We gotta fix it. The guy who's that? We're gonna get ready just in case. That's the hemodynamically stable analysis. All right. QRSs.
Narrow.
Narrow. P waves.
Upright.
Right there.
Maybe. Maybe. Is that a P?
Yeah.
Is that a P?
Yeah.
Is that a P? Maybe that's a T. I don't.
Irregular.
I don't know. Huh. Rates. 300, 150, 175, so whoa. It's very irregular. So I'm just gonna throw a rate out there and say the average rate on this is 72. Okay. PR interval. Oh, I'm sorry, regularity. It's irregular. In fact, it's irregularly irregular. It's not following a path. Okay? And it's kind of got that squiggly line. What does that squiggly line mean? Fibrillation. It means that part of the heart is just quivering, shaking. Right? Different from what's that one? The whole heart is shaking. Right? That's the one we zap with electricity, right? You CPR? Can't be alive with that. Well, in this case, the ventricles are still, well, electrically depolarizing at least. So it's not ventricular fibrillation, it is
Atrial.
atrial fibrillation, AFib. AFib is the only rhythm that is irregular with the quivering line.
The other one was VFib.
The other one was VFib. Right?
You said that again, A for what?
The only rhythm that is irregularly irregular that has this quivering baseline.
So an AFib,
You said-
So the top is going,
yeah, that's.
but the
what-
bottom's going boom. boom.
So, yeah, the ventricles are still fire, they're still contracting as they,
So this up here is just kind of shaking. Is blood getting pumped down? No, but every one of these waves is bombarding that AV node. Boom, 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 boom. And that AV node's like, nope, 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 nope. Send that one through. Nope, 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 nope. And he's letting some of them go through. Enough that the ventricles are contracting. Do I really care what the atria are doing? Ventricles are what pumps blood to the body. Only time this is an issue is if the heart rate is too slow or too fast. Right? So we'll put another one up here.
So is that why you see some people, they,
Ah,
the heart rate
great.
jumps all over? 'Cause
Yep.
it's kind of
Irregularly irregular, very common.
But the ventricle should be beating roughly 40 to 60?
No. It's sending some of the signals through. The rate should be somewhere relatively normal. Right. QRSs. That's 3 boxes. All right? It's right on the limit. It's not a great one for a test, but you get the idea. So it's good. P waves. But this baseline is kind of a little quivering. Is it regular?
No.
It's irregular. It's irregularly irregular. This is also a fib.
so you can go ahead and, like, if it meets these certain qualifications, that's where, like, it's, you're gonna say, like, irregularly irregular AFib. It's.
Yep.
Like, in general.
Oh, here's a good one. QRS.
Narrow.
P wave.
Mm.
It's kind of that quivering line, right?
AFib.
Irregular?
Yes.
Is it irregularly irregular?
Yeah. AFib.
AFib. All right, now I'm going to throw another one at you.
Just how far and close they are apart.
There's a good one. Actually, this is a better one.
Narrow.
QRSs.
Regular.
Narrow,
Yeah.
not ventricular, right? P waves.
Yeah.
No, this looks like, they call it a sawtooth, like if you looked at the bottom of a saw, or a picket fence, top of a picket fence. Right, so they call it either a sawtooth pattern or a picket fence pattern. Right? Those are called flutter waves. The atria, the signal didn't start here, it started somewhere in the atria, and it is going way too fast, like 300 plus times a minute. So if I look, all right, let me see if I can find one on the line, boom, 300, the atria are doing 300 beats a minute. Boom, 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 boom. Well, what is the SA, or the AV node doing? It's letting every fourth one through. Boom, 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 boom. And it keeps the ventricles at a
Consistent pace.
normal rate. Now, this happens to be regular, because it's a 4-to-1 ratio. Atrial flutter. Okay? It can be that's a 2-to-1. You see this sawtooth pattern? Right? But it can also be irregular, doesn't have to be regular, like here, 1, 2, 3, it went through 1, 2, 3, went through 1, 2, it went through 1, 2, 3, So atrial flutter can be either.
Regular or irregular.
Yes. But regardless, you get that picket fence, sawtooth pattern.
So as long as it has
You
that.
see that, that's what it is, end of discussion. It's just, oh, go to.
So is it safe to say that it's like one of the most recognizable
Yeah,
lines about a flutter is that sawtooth or picket fence, it doesn't matter as long as you see that, gotcha, okay.
don't look at these. These are FOBs, we'll do another day. Whoa.
Narrow.
Narrow,
Narrow.
P-wave.
No.
Third degree.
There.
No P-waves.
No P-waves.
No P-wave.
So where's it come from?
Junction.
Junction. Rate, 300, 150, 100, 75, 60, 50, 35.
Which is low,
Yeah, but it's
yeah.
junctional. They used to call it junctional escape, meaning they can call it Brady, but, because all junctionals are Brady.
So if it's junctional, but it's between 40 and 60, then it's.
Junctional is up to
normal-
60.
Normal junctional?
Yeah, but again, I don't give a damn what that is.
Too
What's my
soft.
patient look like?
Yeah.
Yeah.
The problem is it's too
Slow.
slow. Right? You know, all junctionals. Oh, there we go. Narrow?
Yes,
Is there a P wave?
Yes.
no,
No, no.
Is it far?
Well, then where's this one?
That's the T.
that's
It-
the.
Yeah, you gotta make sure it's consistent for each. All right, so no P waves.
Right.
Rate, 300, 150, 100, 75, so it's about 80.
Yeah.
Accelerated.
Regular, accelerated,
Junction.
junctional. P wave, or QRS,
Yes.
P waves.
No.
Rate, 300, 150, 150.
Accelerated junction.
Super accelerated junctional.
Nope,
Ventricular.
nope.
Tachycardic
It's
junction.
junctional.
Junctional tachycardia.
Over 100.
Tachy means don't look at these.
So 150.
QRS,
Wide.
what does it mean?
Ventricular,
Heart rate.
150.
Tachycardia.
Ventricular tachycardia.
Boom. VTAC.
Yeah.
That's.
Forsyth, yeah.
Which is a type of
VTAC.
VTAC. It's called polymorphic, many forms. Monomorphic, they all look the same. Polymorphic, they look a little different. It gets bigger, smaller, smaller. That's torsade. What's my drug?
Mag. 1 and 2 milligrams.
Grams.
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 Grams. That's why you always double check.
Signal 7.
Pretty close. Could be, but if it's not artifact.
That's still tors.
No.
No.
There's no.
That's V-fib.
That's PDA.
V-fib. Torsades, it's following that pattern. It's either all the same or it follows that pattern. Is it following a pattern here?
No.
It's not a regular pattern. That's V-fib. It's just quivering. Okay?
Does torsades ventricular as well?
Yes.
So that'll be
V-fib.
obvious because they're dead, right?
You would think.
Like, no one like walking and talking would look like that.
Zombie.
Okay.
No, valid question. If all of a sudden it's like, boom, the alarm goes off and you see that, and you look, your patient goes, oh my God, what's wrong? Maybe the wire popped off. But don't forget the common sense. You can't be alive with that. It means the heart is not pumping. So this is actually coarse meaning tall, VFib, getting into normal VFib, getting into fine VFib. And what happens is there's still electrical activity going on in the heart, but as the heart dies, you get less and less electrical activity. So that first one we saw, he'd been dead for like 2 minutes. He'd been dead for like 10 minutes. It gets smaller and smaller until it goes flatline. Now, is it truly ever perfectly flat? But I want to ask this one question. Right, flatline. That was one camera angle, right? And we proved, even though this looked normal from his perspective, it looks flat. So there is a rule for a systole. That's treatment. You have to look in 2 or more leads. Don't do a 12 lead. You don't do 12 leads. 2 or more views. If this was lead 2, and I saw nothing, no electrical movement, and I looked at lead 1 or 3 and saw no movement, ain't nothing. This is not something they survive. This is usually death. The exception to this rule, tuck this in the back of your brain, the electrical shock, the lightning strike, they go to this, and there's an excellent chance you'll get their heart restarted. But if it wasn't from electricity or lightning, your chance of survival is almost 0. Right? So, not saying not to work them, follow your agency protocols, but this is usually more of a confirmation of death than of life. So, hopefully I didn't overwhelm you too much with this. I know a lot of this is going, oh my God. I wanted to introduce this, give you guys a little time to digest this before next week. We're going to talk about this in lecture next week. This is what we're going to do in lab, and then we'll start doing a couple basic scenarios of, hey, it's too slow, let's fix it. Hey, it's too fast, let's fix it, type things. I know you're getting ready to go, that's fine. I want to take no more than 10 minutes, and then I'll stay for whoever wants to stay, because you do have a drug quiz when you come back. 2 drugs, amiodarone, lidocaine. Yes, amiodarone and lidocaine. Number 1, well, first one, top of the heart, bottom of the heart. These 2 drugs work on the bottom of the heart. So what type of ECGs do you think they work on? Bingo, ventricular. Right? So, amiodarone, right? The iodo is for iodine. Iodine is one of the main ingredients in amiodarone. Okay? It is a class 4 antidysrhythmic drug. It is a sodium channel blocker, potassium channel blocker, calcium channel blocker, and it does have some beta blocker properties. It does it all. It's marketed as the miracle wonder drug. Okay? It ain't. Expensive as shit. It's about $300 and something a dose. Lidocaine's about $1. So, interesting study. They used lidocaine. We've used lidocaine forever. We know it works because we always did it that way. And they studied ROS, return of spontaneous circulation, cardiac arrest. And they found with lidocaine, we get pulses back about 7% of the time.
That ain't a lot.
No. And then they did the same study with amiodarone, and they went, oh my God. We get pulses back about 96% of the time. Holy shit. I don't care about cost. Like, it's the miracle bullet, right? It's going to save everybody. No, the study meant at some point the heart went, boom. We got a return of spontaneous circulation. So they went back and did a retro on a study. And they took the same patients that they studied lidocaine on, and the same patients they studied amiodarone, and did follow-ups. They went, wow, For every 100 patients with lidocaine, we got a pulse back on 7 of them, and 2 of them left the hospital alive. And on amiodarone, for those same 100 patients, we got pulses back on 96 of them, and 2 of them left the hospital alive. Right. Most places will still recommend amiodarone because it is better, you have a better chance of getting a heart restart. We're not seeing significant clinical overall hospital discharge outcomes. So amiodarone does all these things. It can be used for atrial stuff, but really it's used for ventricular rhythms. VTAC, VFib. Right? Now VTAC might have a pulse, might not. If it doesn't have a pulse, we treat it like it's VFib. So there's the cardiac arrest dose and then the VTAC dose. Cardiac arrest for amiodarone, 300 milligrams first dose. Second dose, if you need to, is 150 milligrams. And guess what the max is? 450. You only get twice. Pediatric dose, 5 milligrams per kilogram. All right. Onset is pretty quick. Now, the not cardiac arrest dose, the VTAC dose, we did this in lab last semester. 150 milligrams over 10 minutes. If I give it too fast, it drops their blood pressure. So why can I push it as a bolus in cardiac arrest?
There is no blood pressure.
There is no blood pressure. Can't get below 0, can it? Right? They're already dead. So the simplest way to do the amio drip, put 150 in an IV bag. I don't care what size IV bag. Put it in an IV bag. If I used a 10-drop drip set and I wanted to last for 10 minutes, in the math problem, the 10s will cross off. I'm going to be left with however big the bag is how many drops I need to give. If I put it in a 50 bag, I need 50 drops a minute. If I put it in a 100 bag, I need 100 drops a minute. You get the idea. Right? Make it last for 10 minutes. If their blood pressure is falling, just slow it down. Don't give it so fast. Now, it does talk about the post-resuscitation dose in there. I'll mention it, but I'm not going to quiz you on it. Technically, if you get them back after giving amiodarone and cardiac arrest, we're supposed to do a fast infusion and then a slow infusion. Fast infusion is 1 milligram a minute for 6 hours. And then a slow infusion is a 0.5 milligram a minute for the next 18 hours. I'm going to ask this question. Are you going to make it to an emergency room with your critical cardiac patient in under 6 hours? And don't worry about it. Okay? Right? It's going to last long enough that they can deal with it at the hospital. So 150 for over 10 minutes if they have a pulse, 300 bolus if they don't have a pulse, VFib, and pediatric is 5 milligrams per kilogram. In either situation, either as a bolus or a 10 milligram. Pretty simple. Amio, also known as pacerone or cortisone. Lidocaine, on the other hand, a little different. Lidocaine, right? Cane-based drug like cocaine. Woo-hoo. Yeah, party drug. Woo-hoo, yayo. Right? A lot of people use cocaine.
Get going.
Right? It has a numbing agent. You ever been to the dentist? Gotten
Ooh, Novocaine.
Novocaine?
Hate that shit.
It's a numbing agent. What do you think lidocaine is?
Numbing agent.
You ever had stitches?
Oh, they lidocaine.
Probably use blue lidocaine. Numb the area up so they can stitch you up. Right? So if somebody's allergic to Novocaine, they are probably allergic to lidocaine. Cane-based drugs. Right? So it is a antidysrhythmic and a kind of a numbing agent. And we use it for the antidysrhythmic properties. And it has a couple other uses. Right? So it's more of a sodium channel blocker, so it's going to slow down that depolarization process. So it's used for those super fast ventricular rhythms to slow them down. Cardiac arrest, 1.5 milligrams, 1 to 1.5 milligrams per kilogram. I know, math, can you do 1 milligram per kilogram in your head? So not crazy hard, right?
Does it have a max or no?
For-
Oh.
So you can, but your second dose is half your first dose, and your third dose is the same as your second dose.
So it's weight based, there's no max, it's a max of whatever their weight is.
3 per kilogram is your max.
So you have 3, and your max dose is 3, then your second.
So my first dose is 1 to 1.5, so let's say I did 1.5.
Your third dose is
So,
1.5.
so let me do some basics real quick. 100 kilos, 1.5 milligrams per kilogram. My first dose would be 150.
Okay, that's what I'm getting.
My first dose would be 150.
Right.
My second dose is half the first dose.
So 75.
And my third dose would be the same as my second dose.
So 75.
So 75, 75, 150 is
3.
3 milligrams per kilogram. That's your max that you can give somebody. 3 doses. Follow me on that?
Got you.
So 1 to 1.5 milligrams per kilogram, second one is 0.5 to 0.75 milligrams per kilogram, half the first dose, just make it simple, you know. Pediatrics, 1 milligram per kilogram, make your math simple. So what I'm hearing here is 1 milligram per kilogram. Keep life easy, but common sense is, oh, he's about 90 kilos. There's 100 in the box. 100. You need 90 to 135, right? So like, don't overthink the math. All right. Side effects with either of these drugs, you can get seizures, you can have decreased LOC, hypotension, maybe a little cardiac chest pain. Lidocaine. After I give it, it doesn't last very long, so I need to include an infusion. So if the lidocaine worked, I then need to hang a drip, a piggyback drip, and my dose is 1 to 4 milligrams every minute. Lots of different ways you can mix it, but it's 1 to 4 milligrams per minute. The rough street rule, not written in any book, but the rough street rule. If I gave 1 dose, go 1 milligram a minute. If I gave 2 doses, never did. 2 milligrams a minute. If I gave 3 doses, get the idea? It's not an absolute, but it's a pretty good street rule. Pediatrics is 20 to 50 mics per kilogram per minute. Right. Rarely do we need to use this in pediatrics. So, usually in adult milk. There are other uses for it. As a numbing agent, sometimes when we do IOs, especially if somebody is alive and conscious, the drill part don't hurt. Hurts a little bit. It's pushing the fluids in afterwards it hurts because the bone can't expand. So they put a little lidocaine in there, numbs up the nerve so they don't feel the pain. Usually dose is 40 milligrams on that.
You give it what? So,
IO.
Oh, you push that first.
No, you do the IO, then you push the lidocaine through it, and then you run your fluids in.
Gotcha.
Again, Volusia County doesn't do that. That's not your protocol here.
We carry a lidocaine in our IO box.
They may have changed it. Dr. Gershon may have changed it. For years, it was not in the protocols.
Yeah.
The other one is lidocaine does have an effect on blunting or preventing ICP from getting higher in intubation. When I put my laryngoscope in and I stimulate the vagus nerve because it's in the vallecula, or lifting the epiglottis, it blocks the signal going up to the brain. It doesn't let the pressure get any higher. So it may be used with the elevated ICP head injury type patient that I'm trying to intubate. Again, that's a protocol really. It's usually 1 milligram per kilogram. Same dose. So nothing too crazy weird on either of those drugs. But the key is they are for the ventricles. The next 2 drugs you're going to do are adenosine and cardizem, which are going to work on the atria. All right. Unless anybody wants to stay and hang out and more shit.
Yeah, I have a question.
Sure. But